we are operating in a capitalistic marketplace for healthcare. I would say at the end of the day, even though some folks might say our CFOs think differently, I actually think they're good folks and they're not just about maximizing profit. They actually do want to improve the health of folks and this idea of zero transaction. So all this stuff, I would say, healthcare is we're not in a market. We don't have the tenants needed for us to be in a market. So if you go to the next slide, but we're America, and we believe in markets. And I'm not here to like bash markets or bash capitalism. I have an iPhone. I buy things on Amazon. So I'm not like making a statement about markets in general. I'm happy to have that conversation some other time. But just for healthcare, I would say that we are poorly set up, but we're America, and we've kind of allowed the market to be the solution to date for the most part. If you go to the next slide. And so what that's led to, I would say, is this, which is, I mean, this is shameful. I mean, we're spending so much money, and and look at that. I mean, that's the opioid epidemic there at the tail end for the U.S. But like our life expectancy, and you could like put up different quality metrics. I think it's kind of a broad one that everyone would say is important. I mean, we're doing a very poor job for how much money we spend on health expenditures. Go to the next slide. So that's kind of the idea of market. So as I was saying, I'm just kind of framing up of the healthcare insurance market. That's kind of my commentary on the market part. Now I'll talk a little bit about health insurance and the origins of employer-sponsored health insurance in the U.S. Is World War II. So probably most folks know this, but in World War II, actually the government said you can't raise wages because there aren't enough employees, and then you're going to actually have to pay people a lot of money, which one might argue is fine and good, but the government at that time said it's not fine and good. And so employers started to add benefits to try to attract employees. And so they added health insurance back in 1942 to try to attract employees to work for them. And that's kind of the origin, and then it's just kind of carried through. So if you go to the next slide, what I would say is, when you think about insurance, it's a coverage by contract whereby one party undertakes to indemnify or guarantee another person against unexpected loss. Right. So I underscored here unexpected loss. So if you click the space bar or go to so back in the 1940s, healthcare really was unexpected expenditures. I mean, these are things in 1900 that were probably not that different than in the 1940s that were killing people. Pneumonia, TB, GI infections. I mean, these are unexpected costs. So actually insurance makes sense when you have unexpected costs. But now in 2010, 2020, these are not unexpected things that are killing heart disease, cancer. I mean, kind of they might be a little bit unexpected, but like this is chronic disease. It's just a different world. So this idea that we need an insurance to guarantee us against an unexpected loss is not what it's not what healthcare is these days. Certainly there's some of it. There's accidents and things, but for the most part, it's not what healthcare is. So if you go to the next slide, so this is kind of how I would compare the idea of an insurance, like car insurance versus health insurance. So if you have routine maintenance, if you take your car into the shop, it's not like your car insurance covers that, but your health insurance covers you to see the PCP. If you need to like change your tire, your insurance doesn't cover that, but health insurance covers you to change your knee, get your knee replacement. If you have an unexpected event, an accident, okay, so that's what car insurance is. And okay, so maybe that would be an insurance, like you have a heart attack. But for the most part, what we have is health. We have health care, and we have a health care payment, but we don't. It's not really insurance. So if you go to the next slide, and this is what happens when you kind of think of it that way. I think for the most part, you think of it not as like a service to society, but as an insurance that someone buys, then you get this. So if you go to the next slide, and so, but and we have to change this. So I just put this up here to say, people talk about like wage stagnation, but if you look at it, like wages are creeping up for folks quite slowly, but healthcare costs are going up a lot. And so a lot of, if our if instead of having rising premiums, we could actually have rising salaries, you would see the wages in the US increase quite a bit. But all that extra money is going to pay for our health insurance. So I think I would just put it out there. It's kind of like a moral obligation for us to do this differently. Okay, if you go to the next slide. So healthcare, the problem with the healthcare insurance market is it's not a market and it's not insurance. So we should be having conversations. I don't know. We should be having conversations about healthcare, not a healthcare market, about access to healthcare, not having healthcare insurance. So that's kind of the backdrop. If you go to the next slide, I think I kind of has, but this is where we are. And so in the U.S., we have this healthcare insurance market, and that's how we've approached healthcare, and that's how we've approached financing healthcare. And so, with that financing of healthcare, when we think of it that way, leads to is if you go to the next slide, it leads to so except we actually don't do that. Can anyone see the one country here that's not really a country? The VA system in the U.S. is the eighth largest healthcare financing system in the world. And guess what? They don't have it. They don't think of it as a market. They actually have a totally capitated, government-paid, single-payer healthcare system. So it's not like we don't know how to do this in the U.S. We do. In fact, we have a system in the U.S. that's single-payer, larger than Brazil, larger than Canada, that evil, horrible Canadian system up north. I mean, we are doing it, right? And if you go to the next slide, the VA gives good care. I mean, they highlight, they have poor access to blah, blah, blah. But if you actually look at metrics, the VA provides a better health care in general on objective metrics that you can critique than the U.S. healthcare system writ large. So we know how to do this. We just decided that we don't want to have this same kind of access to healthcare for everyone. We want everyone else to have to engage in the healthcare insurance market. So if you go to the next slide, and so what you get when you have a healthcare insurance market instead of a service of providing healthcare is this fee-for-service payments, which is the more you do, the more money you make, and there's no accountability for patient outcomes. So, until I would say, even still today, depending on how you look at it, if we have complications in healthcare, we actually make more money. If you give the patient the wrong medication and then they have this bad reaction with their other medication and then they end up in the emergency room and then they get admitted, that we make a lot of money on that. It's a good job that or if you don't do a good job of taking care of someone and then they end up with some complication from their diabetes and they have to get an amputation, that's great for the healthcare insurance market. I mean, we're like cranking through, making more money on that. So that's what we have right now for the most part. So if you go to the next slide, and not that everyone, anyway, I mean, we are all, I believe like our orthopedic surgeons and our oncologists, I mean, they're all, I think, entered into medicine to do the right thing. So this isn't like a bash on anyone. So the idea of value-based care is a different way to pay for healthcare. So I'm going to now talk more about what this is, value-based care, and how it's a different way to pay for healthcare. So go to the next slide. So the idea with value-based care is that you pay people for providing good quality care that costs less. So quality is, the outcomes. So are patients' health good? Are they not having complications from their diabetes? Are they not having admissions to the hospital for something that could have been avoided? And then the patient experience, like, do they feel satisfied with the health? And then, people critique those don't always go aligned, but I think it's important to think of both of them as part of quality. And then the cost, which is direct costs and indirect costs. So that's what value is, and that's what value-based healthcare. When I think of it as synonymous. Value-based healthcare is about trying to improve quality and decrease costs. You go to the next slide. And so I'm going to go through these. So in terms of quality, we think about these things. And again, this is like hard to measure, and there are better, more holistic metrics than what the insurance companies measure. But we're still kind of, I would say, in the early stages of being kind of whole person. So we get things like colon cancer screening, hemoglobin A1C control, hypertension control. So that's kind of how we measure quality. And then there are patient satisfaction surveys. If you go to the next slide, cost. This is where we're just like kind of looking at cost, and I think this is just an example of where we see wide variation in costs. And this is not risk adjusted. So I know like sicker patients go to Maine Med, and like Lincoln is a rural place where it's hard to provide service. So this isn't a judgment on any of these systems, but it's just an example of, you can see there's a wide variation in cost. And so is there opportunity there to lower costs? So if you go to the next slide. So a value-based contract, and what I mean by contract is that it's an agreement with an insurance company and a healthcare system or a healthcare ACO. What they do is they set a target. This is how much this care should cost, and then they give you a bunch of quality metrics. And at the end of the year, they sum it all up and they see how you did. So if you go to the next slide, I put a visual there. So it's kind of like, imagine it's 2019 and we're meeting with Anthem. And Anthem says, well, your cost for your, 10,000 patients was $100 million in 2016, and then $105 million. It goes up, and we're in 2019, and it's like whatever, $117 million. So we think next year it's going to bump up to 125 million, and then the year in 2021 it's going to be 130 million. So that's what we're going to target you and try to come under that. So we do a bunch of things, and we like engage primary care because that's where all of value happens. And we say, can you help keep patients healthy and keep them out of the ED and keep them from being admitted? And we do a great job because that's what we do. And we actually decrease that curve. And the patients actually only costed 119 million in 2020, and they only cost 120 million in 2021. And so we come in less than what the actuaries say. So then we call that shared savings. So we saved $10 million here. So we get half of that. And then the insurance company, they kind of get the benefit of kind of getting half of that because they don't have to pay that money out. But then they take our half of it, that 5 million, and they adjust it by our quality score to make sure that we're not just avoiding care. They say you got 90% on your quality score, so you get $5 million times 90%. So that's what a value-based insurance contract is. And so if you go to the next slide. So the Maine Health ACO, we're the part within Maine Health that does those contracts. So we go to Anthem and Harvard Pilgrim and Maine Care and all the insurance companies, and we say, hey, we think value is important. So let's put together that contract, and then let's see if we can come in with high quality and lower costs. And so we have, it's mostly Maine Health. I'd say probably 75% of the Maine Health ACO is made up of Maine Health, but then we do have specialty solutions as part of the ACO, and we have a bunch of primary care, private practice PCPs, and some other private practice specialists. So that's what the ACO is. And if you go to the next slide, and then these are the contracts we have. So we have the Medicare contract, and this Maine Care contract, we've actually now bumped that up to 42,000 because we've expanded it across all of the ACO, Medicare Advantage, commercial contracts. So we have all these. This is the number of people that are kind of covered, so to speak. So it's basically primary care attributed patients. So when you have a patient who has Martin Point Generations Advantage and you're a PCP within the ACO, then your patients are part of this 13,000 that are attributed to us for this contract. Go to the next slide. So now I'm going to talk a little bit about value-based contracting and primary care teams, and what I see is kind of the implications for us. So go to the next slide. So one is, and some of these I think, in general, I think this is, again, a small step in the right direction, but not without its complexities. So one of the things is we're being held responsible for things that are out of our control. So as we all know better than anyone within the healthcare system, health care doesn't happen when it doesn't, for the most part, it doesn't happen when the patient goes to see Dr. Bouchard in his practice. It happens when they go back home and they talk with their family about what that Dr. Bouchard said they should do, and it happens when they go to the grocery store and they are able to buy healthy foods, and it happens when they have a job that pays them enough money to to engage in their health or not. So it's a lot of things out of our control, and I'd say I think of it as similar like to a school. I mean, we have these children, and some of them uh, have parents like many of us who have a stable job and have a stable income, and we can support them with their schooling. And then many of them have um, home lives that are disruptive for a number of reasons. Their parents who have to work two jobs, or there's addiction in the house, or but the teachers are still like held to like, okay, these are the tests and all the students, and then so, but we don't stop testing kids. So it's imperfect, but I think the nice thing here for us is um, I think we all believe that we need to push more into this kind of community, engaging with the community around health, and value-based contracts give us kind of an opportunity to say, okay, if we're actually trying to drive a decrease in admissions, a lot of that, or readmissions, a lot of that is because when the patient gets readmitted or gets discharged, and they get discharged to the street because they're homeless, and then there's like a readmissions, and we're like, oh, well, maybe our intervention needs to go beyond just the healthcare system. But it's hard. It's hard for us, and I know we all have patients where you're like, I've been trying for 5 years to help them with their diabetes, and I can't get it. So if you go to the next slide, it also means kind of more oversight. And I think I get my Elizabeth. I see patients at the OPD clinic, and Elizabeth Eisenhart once a month comes by with my little um, quality metric scorecard, and I'm like, yay, yay, don't, oh yeah. And so I don't like necessarily getting all that oversight, but I think as a system, it's important for us to see like where are there variations in care and where are there variations in quality, and where can we identify the positive outliers to say, geez, Portland Family Med has really nailed this thing. How can we translate that to Westbrook Family Med? The other things I would say is that, so one is imperfect. Risk adjustment matters. So this is meaning that they weigh the variations in care by how sick your patients are. So when you have a patient who's at Scarborough Family Med and they have like severe heart failure and they have significant COPD and they have had 3 heart attacks in the last 5 years, that patient, and they go to the hospital, that should be those complexities should kind of say, people be like, yeah, well, we might expect that patient to go to the hospital once a year. Whereas if you have someone who's like 40 years old and really healthy, maybe they shouldn't go to the hospital, or maybe they could have avoided the ED. So, but that risk adjustment tells the insurance company, like, these patients are sicker, so expect them to cost more. These patients aren't as sick, so expect them to cost less. And similarly for quality.
Hey, Rob,
yeah.
Can I chime in? So this is one of those moments where things sort of slip into context, where we talk about coding. We're like, you need to do the HCC code. You need to do that. It's actually to support this stuff, because if our patients all look like they just occasionally have sore throats, we don't actually benefit from taking care of complicated patients. And it's not about billing them more. It's about getting more to take care of the population, which is on average sicker than maybe a population that we didn't bother to, try to prove, essentially. Because if we just have a whole bunch of healthy people, we probably don't deserve as much money to take care of them as if we have a bunch of complex folks. So that's, these HCC codes seem kind of out of context, but then when you see the big picture and that this benefits the way we take care of our whole population, then it starts to kind of make sense.
Thank you, Beth. Thank you for highlighting that. And the payers only know how sick a patient is because on the diagnosis code, when you like put in your diagnosis code, then it goes to them with a chart, and then they load it up. And it's really important. And in fact, to the point that we're entering this primary care first, and they are paying us for every patient either $28 a month or $45 a month, based upon how sick they think our patients are. And I'll say everywhere in Maine Health, we're only getting $25 a month because the insurance companies think, oh, your patient's actually pretty healthy based upon your codes, except for actually at the OPD clinics where they're getting $45 per month for the patients. So it actually, relates directly. So when I think about the patients that we care for within our family med practices, I know that there's some sick patients, and I think like we deserve $45 so we can like have the health coach and we can pay for our care manager. So um, but the insurance companies are like, well, we don't know if they're sick. Their code says they just have like this simple thing. But so the next thing I would say is this stinks the least. This sucks the least. So this kind of like oversight. It's so imperfect, and our quality measurements are so imperfect, and they don't capture the full whole person context. But it's what we have with the information we have. And then I would say like these last two kind of go together. I would say like we have to help the system get better. Get that's a typo, but I'll just pretend I meant to emphasize it. We have to help it get better, and we can't spend energy railing against it because it is what it is. And like if you rail against it, you'll just make yourself miserable. And this is an article. If anyone wants to check it out. Rethinking quality improvement in the wake of a pandemic. And I think actually the Pop Health Committee might have sent this out recently. But it's a great article. That's one doctor's proposal of how to rethink quality improvement to be more holistic. And I'm like, that's great. And then I took it to someone who works out with payers, and like, pairs aren't there yet, but yes, it's great. So I think we can all make it better. So if you go to the next slide. The next thing is, what does it mean for our teams? It's better care for our patients. So I really believe this is a focus on keeping patients healthy. So investments in home support to help like post-discharge. Like there's studies that show when you give someone meals after they get discharged from the hospital, guess what? They actually have fewer readmissions. And so can we operationalize that? We have teams that help us to track down quality gaps, which sounds kind of wonky, but I actually, when I look at my list and I'm like, oh my God, that's right, that patient has an A1C of 10 and they no-showed in July and I haven't followed up with them. I'm like, oh, I'm glad someone is following up with them because I obviously missed it. It's like home-based monitoring devices to prevent admission. So I think it's investments in this that there's a financial argument for when you're in a value-based contract. Let's go to the next slide. And it's better teams. I mean, I think we have great teams here, but I mean, we need more Corinnes, and we need more. I mean, like we need more of our care managers, and we need more of our we need more of team. And so I think that when we can, when we're being held accountable for like keeping patients healthy, we do that through more of all of you. So if you go to the next slide. And then I would say the last thing, what it means for a primary care team, and this I will throw out there, but I think some people might cringe, but I'm going to put it out there anyways. Costs matter, and I think that it can't always only be about the patient in front of you all the time. So I think there's this concept that I'm not an expert on, so please don't, but this concept of contributive justice. Like if we're all contributing into this thing, but then you drain that stuff for certain people when it doesn't really drive improvement. I think there's kind of a justice thing there. And so I think that it's important for us to be willing to engage. And I'm sure we all have like both family and also patient experience of this, but be willing to engage in that really difficult conversation with the patient who is thinking about going on to like the $50,000 a month chemotherapy that studies show only extends their life by 7 days. I mean, I think it's kind of incumbent upon us to start thinking about that, and that's hard when you're talking about hope and you're talking about difficult things, but I think it's going to be part of our job, and we should take it on, even though I hate those conversations. All right, go to the next slide. So in summary, and I think I might have time to jump to some primary care specific stuff. The value we get from our healthcare system is the lowest in the West. There's not a great word for this, but I'll just say Western world. The healthcare insurance industry has almost no other factors necessary for efficiency through market-based competition. It's not really an insurance, but it's more of a service with an insurance component, like because there are accidents. The healthcare insurance market has led to fee-for-service payment. The VA system is a non-fee-for-service model that provides much higher value care than the rest of the U.S. Certainly there are pockets where that's not true, but in general. Value-based care payment models are a small step in the right direction. It's hard to imagine this won't continue. So even under the Trump administration, this move towards value-based contracts has continued unslowed, and so it will continue to progress. Overall, I think this is good for primary care because, I mean, in truth, what's good for patients is good for primary care because we drive most of the value to patients in the healthcare system. Next slide. For primary care teams, I think this means like broader accountability for patient outcomes, ongoing imperfect and quality and value measurement systems. But ultimately, I do think it can lead to better care for our patients. When I say better teams here, I mean kind of like just bigger teams. And I think there's something about thinking beyond the individual and just kind of like thinking about society. So I sent Christine another presentation where I can go like through maybe 5 slides, make it even more real to primary care. But I'll pause here just to see if anyone has any questions. Yeah, Beth.
I was just going to say, I think there's this weird thing when we talk about reducing cost and we talk about keeping people out of the ER, keeping people out of the hospital. There's a little bit of a knee jerk of like, but don't people want people in the hospital because it makes a lot of money? So what we talk about is low value stuff. So what we're trying to keep out of the ER is stuff that takes up the beds, takes up the nursing staff, takes up the physicians' time when they could be dealing with sick people, but instead those people get sent somewhere else because they've got a bunch of UTIs lined up in the ER. It's the same with the hospital. We want people who are the highest risk and the sickest to be in the hospital. The people who don't need to be there, we don't want them there. They get complications. It's bad news. So in fact, even for specialty care, like when we talk about better referral systems where we kind of triage people a little bit more so that not everyone gets sent to the specialist, they've looked at it and it actually is good for specialists because instead of getting every single rash, right, and like clogging up the works and never seeing the people with really interesting, potentially sort of things that need treatment, things that, you know, need more exploration, they're just seeing nothing. And so they're wasting a ton of their time on this very low value care. So it's not that we in primary care are trying to like keep other people in the system from making money. We're trying to actually reduce low value cost for everyone, which actually does benefit the hospital and the specialist. So we're not sort of, and that took me a while to wrap my head around because it makes it sound like we're on this path to like not send specialist people and not send people to the ER, but it's more that we're on the path to take good care of them so that the people who really need those services get them, and then everyone benefits.
Thank you, Beth. That's a great clarification because it's not about like pitting primary care against these other systems. We need these great systems, but it's about the low value. So thank you.
I just wanted to say a few things. I used to fight these battles of trying to get the support necessary to do advanced primary care or patient care first or whatever you want to call it over the years with the hospital. And the hospital really, it is a profit and loss situation. I don't think there's anything in the past that was driving them to make the investments that were needed to be made in the past due to loss of revenue. I mean, we had one program where we decreased readmissions for people with, we call them I can't remember what it was, the very highest risk patients. We had a social worker just working with them one-on-one, going to doctor's visits, etc. And we, cut like $200,000 worth of admissions. I mean, it more than paid for this social worker's salary, but it also decreased revenue. And, when it was brought up at the board, that was noted. So hopefully, you know, as we move from fee for service and from a hospital standpoint to value-based care, hopefully that will change their approach and how they make decisions on where they should support which type of, you know, where they should put the financial support in the healthcare system. But, you know, it's been, as you know, a long road for that.
It's a great point, and that's why I say I think this idea of value-based contracts and shared savings is a small step, because if you save the insurance company $10 million because you decreased hospital revenue by $10 million, you only get $5 million of that back. So we're not. It's kind of like almost like it's the first step. It's in the right direction, but I think people could argue that it's not enough of a financial incentive. And I think it's interesting when I had these conversations. I think leading with but this is the right thing for patients goes a long way. And so the best point of like, but is it not right for patients to be getting the care they need to stay out of the hospital? But is it not? And so that doesn't necessarily lead to therefore we're going to make these investments. But I think people can't disagree with but I think you're right, Mark. It's hard.
It is hard, and I do think that I think it's shifted a little bit in the last few years at Maine Med, partly because we're stuffed to the gills, so they're now sort of like, get patients out, and also now the whole system has to look at utilization, which I think is kind of new, like that they're actually saying, like when you go to meetings now, they bring up ER visits and utilization, like I didn't hear that 3 years ago, and I feel like that's slowly shifting too.
So let me go through a few of these slides because they might raise more questions. I'm going to talk, so population-based payments, I would say this is instead of shared savings, this is a different form of value-based care contract. So if you go to the next slide, thank you for pulling these up. So you can go to the next slide. This is from a different presentation, but so just to start with, by definition, what we're talking about here is prospectively paid. So before you actually see the patient, so at the beginning of the year, you get this risk adjusted. So again, this gets back to what Beth highlighted, per member per month payment for primary care services. So this is not total cost of care capitation, but most of these do include incentives to manage that. But it's really what I was saying before, like Portland Family Med, starting January 1st, for your Medicare, like not Medicare Advantage, but your plain Medicare patients, you will be getting $24 per member per month to care for all of your patients. So if you have, let's say you have 100 of them, then you're going to get $2,400 a month to care for those patients, however you think you should care for them. That's the basic idea here. Now, primary care first, which is the value-based contract with Medicare and Portland Family Med, it's not strictly population-based payments. They actually have a little bit of a fee for service that they left on there because they are worried about moving totally away from fee for service. So you still get actually $50 every time you see the patient. So you get $24 per month plus $50 when you see the patient. I think in the future they might just say, okay, let's move away from that $50 when you see the patient and just make it like $35 per member per month and do whatever you want. And that's what we'd like. I would say the objective of this is to provide us flexibility. Objective, like why I'm interested in this, and I know like Beth is interested in this, and probably other of you, is that it gives us the flexibility to design care around value. So now we can say, okay, so now we have $2,400 a month. How do we want to invest in our teams to take care of these patients? Instead of saying like, oh, well, we're only going to get paid when Dr. Rothenberg sees a patient, so let's hire a bunch more Dr. Rothenbergs. Instead, we could be like, oh, well, we're getting paid like this. Should we hire some more of other people, or should we blah, blah, blah? You can kind of have that flexibility. If you go to the next slide, I'm going to skip some of this just to get to some of the main points. You go to the next slide. So people are getting into this. MaineCare is actually going to start paying us, offering the opportunity to engage in a contract like this next year. That would probably start a year from this January, so January 2022. but they're on board. Other insurance companies are doing it because they know actually when you guess what? If you actually let primary care design around value, they deliver even more value. And you stop like holding them to the shackle of fee for service, they can do an even better job than they are, which when we do a good job in the fee for service payment system. Go to the next slide. So the problem is we are small. We're like 5 to 7% of overall healthcare costs, we being primary care, but we direct a ton of this spend. And so everyone asks us to do more, and we throw up heat maps and we give us reports, but we don't have the teams to actually to realize our potential. And so fee for service just limits our ability to do that. So go to the next slide. So this is kind of, again, the idea of like a big team can get paid for in population-based payment, or just these few people that can actually bill in our current fee for service. So this quote, you don't have to worry about what fees are paid for what services by what provider. So go to the next slide. So these are all the things that we all know so well that we don't optimize. And to Mark's point, like you bring this forward to you like put your pro forma together to hire your health coach, and they're like, so where's the revenue coming from? How many more patients is Dr. Peterson going to see to pay for that health coach? You can kind of get out of that when you get into these population-based payments. So you go to the next slide. So this is just saying like we have all these wonky workflows so that we as doctors or APPs can bill. And so it's just kind of like a little cartoon here saying we could do much more if we don't rely on a PCP who bills. Go to the next slide. And it provides better access because you have a bunch more access points for patients, because it's not like, oh, they're calling. Is there an APP or doc who can see them? Because the nurses certainly aren't going to, because the nurses don't get paid, and well, the health coach, we don't even have those. But you get into a population-based payment, you'd be like, oh, let's have them see the nurse, because it's not about payment anymore. It's not about who can bill anymore. Let's have them see the pharmacist. So you go to the next slide. And I think it just gives us more autonomy to design our primary care as we want, and that could help with burnout. And I want to recognize, like, this is not a panacea, and there will still be hard things about being a primary care doc, and we'll still like feel a ton of pressure, and probably during our like pre-visit planning at 6 a.m. But I think it would help us towards burnout. Go to the next slide. Then if you go to the next slide. So this is just like, it's an investment in primary care, and primary care makes low value utilization less likely, and that's how we decrease cost. If you go to the next slide. And then these are some of our own physician leaders at Maine Health who say like, yeah, actually this is a good idea. Primary care capitation is another way to say this, but I'm trying to get away from that terminology because I think it carries negative connotations. But it's, the concept, you capitate the amount of money for these patients and you give it, but I think population-based payments makes better. Then go to the next slide. And then the next slide. So I'm going to stop here. This will be my last one. But the way this would work is you get a per member per month. And this is based upon what you do in primary care. They kind of total it all up, how many patients are attributed to you. I don't know if I need to go on. You keep some things as fee for service because you want to incent the primary care doc. Like, hey, if you do punch biopsies, please keep doing that. And we'll actually give you $15 for that. So you don't refer them to the dermatologist because that's going to cost more money. So you kind of like create these incentives. You create these carve outs so you don't disincent high value care, which is having more done in primary care. Then you adjust it for the patients, how sick they are. And then you layer on these quality metrics to make sure that the primary care docs, which we would never do, but aren't just saying like, we're never going to see you and we're just going to bank all this money. And then you overlay a total cost of care incentive. And so the way this works is you say like, okay, if those patients should cost $100,000 and they come in at $110,000 at the end of the year, then next year we're going to dock your PMPMs. So instead of getting $28 per member per month, now you only get 26. Or if they come in under, instead of getting $28 per member per month, you're going to get 30. And so from the health system standpoint, it's safer because you're not capitating, you're not putting a global budget on the whole healthcare system. You're just kind of, again, in that 5 to 7% window. So this is work that Beth and I have been working a lot on this in multiple different rooms and with different folks, and we're really trying to think about how to advance this. Portland, Westbrook Family Med, all of our primary care practices have actually signed up for this for something like this for the Medicare patients. Medicaid is going to be going for this. I've had conversations now with Anthem, Harvard Pilgrim, Aetna, and United around this, and so it'll take a while to get us there. But if we can get there, I think it would be good for our patients. I just think it'd be good for our patients because ultimately this is about bigger teams, hopefully, and I think it would be good for us within primary care. But I'll pause to take any questions about this.
Thanks, Rob. This is Deb. I wrote a question, and I think it's a broader question. My question that I wrote was, does this mean we wouldn't have to code visits? But I'm wondering how this impacts people who work for the system, like our coders or our insurers, in terms of numbers of people and the task that then trickles down to the physician to have to do to not document the visit, but document the cost. Does that change all of that in terms of the widgets that we have to do now?
Great question. So if we could get here, you wouldn't have to do the same level of documentation to say this is a 99214 or this is a 99213. So that would kind of go away. If say all your patients are paid this way, you'd still have to code to say this patient has stage 3 heart failure, this patient has diabetes with complications, because that affects your risk adjustment. So you still have to do that. And then in terms of the cost, the insurance company tracks that. So the insurance company is the one who's going to say your patient should have cost $1 million and they only cost 900,000. So we don't have to do that. We would want to develop reports internally to say, okay, admissions drive costs. So what are we doing to drive down admissions? And to Beth's point, low value admissions. So.
But that's, like, to me, a more meaningful thing to pay attention to. What stage of heart failure do they have, or the kinds of things that our medical brains are taught to think around, rather than how many problems did I code? So how many problems did I address? So what can I code?
Right. Like, is that a moderate level of decision making, or is that a blah, blah, blah? That would kind of nicely go away.
So we're coming to the end of the hour, and you're gonna start seeing people leave. And I do think that gets at the essence of it. Is it's not just value money, it's value quality and value time, and hopefully value not just checking boxes. My sense is that no one's going to lose their job because they're not coding anymore. They're just going to be shifted towards doing, hopefully things that seem more patient-centered, to figure out, well, what are the risks? I mean, we already have teams running around the hospital reviewing things to be like, oh, you're not actually looking at people's risks, and really, making sure that we're documenting that. And we're going to do more and more of that, I think, in outpatient. And hopefully, again, it's not great value for physicians to spend a ton of time recoding everybody. And so trying to think about also how to, again, use our team and leverage people who have skill sets that maybe others don't. Rob, thank you so much. I feel like I could listen to this all day. I think maybe it's a small step, but it seems like a big step to me, because I feel like if we're not going in the right direction, then we're just spinning our wheels and creating all these great ideas and then not able to actualize them.
So I think in a country where it feels like sometimes we're not in the right direction, this is nice. I think this is the right direction, which says something, and I think the implications are big. So, and thank you for the invitation, and it's so nice to see you all.
Thanks, Rob.
All right.
Bye, everyone.